Today, we're taking a highly technical clinical pathway and translating it into a premium diagnostic masterclass designed for the modern hematologist. We're going to map out every critical decision point, right from that very first abnormal lab result all the way to advanced genomic risk and treatment algorithms.
Let's start with our golden rule. You see, discovering a monoclonal protein is just the first clue in a high-stakes clinical investigation. It's absolutely not the final answer. The actual diagnosis depends on an incredibly intricate combination of clone size, distribution, organ injury, and advanced imaging.
Here is our roadmap for today. We'll be moving through the monoclonal clue, the 5-question framework, bone marrow and imaging, WHO classifications, divergent pathways, and finally, treatment and minimal residual disease.
All right, let's jump into section 1, the monoclonal clue.
First things first, we've got to distinguish our primary suspect. A monoclonal pattern shows up as this narrow, discrete electrophoretic band with a single heavy or light chain and an abnormal free light chain ratio. That signals a potential clonal disorder. Now, this sharply contrasts with a polyclonal pattern, which is a broad-based elevation driven by reactive states like infections or inflammation. We are specifically hunting for that discrete clone.
Moving right along to Section 2, the 5-question framework.
Think of this as the hematologist's cognitive funnel. Asking these 5 specific questions in this exact order prevents you from making 2 major mistakes, either over-treating a harmless MGS or totally missing a small but highly toxic clone. So what is the protein? What is the clone? How large is it? Is it causing harm? And finally, is there an emergency?
To actually answer those crucial questions, no single test is going to cut it. You have to deploy a comprehensive initial panel, basically a mandatory diagnostic dragnet. Relying on a serum protein electrophoresis alone, for instance, might cause you to completely miss a light chain disease. You need the full combination of serum, urine, and general laboratory studies to build a complete picture.
So here's the absolute crucial point: attribution. Discovering anemia or renal failure means literally nothing if it's caused by diabetes, iron deficiency, or hypertension, rather than the plasma cell clone itself. You must connect the clinical injury directly back to the neoplastic cells.
Let's move to Section 3, bone marrow and imaging selection. To get a complete marrow assessment, you really have to synthesize multiple high-resolution viewpoints. We integrate the aspirate percentage with flow cytometry to detect aberrant phenotypes, like neoplastic cells that are CD138 positive but CD19 negative. And critically, we have to run cytogenetics and FISH on enriched plasma cells to define genomic risk. We're hunting for drivers like translocation 1114 or a high-risk deletion 17p.
When it comes to imaging, the traditional skeletal survey is totally obsolete as a sole method today. Sensitive whole-body imaging is completely mandatory. We rely on low-dose CT for cortical destruction, whole-body MRI to spot marrow infiltration, and PET-CT to track metabolically active extramedullary disease.
Which brings us to Section 4, the WHO plasma cell classifications.
What's really fascinating here is the continuum. A patient moves from MGUS to smoldering myeloma based purely on tumor burden, specifically crossing that 10% marrow threshold. But a patient only crosses into active myeloma when CRAB or SLIM criteria trigger actual, verifiable organ injury, completely regardless of the M protein size.
And speaking of SLIM, these specific biomarkers are hyper-important. If a patient has 60% or more marrow plasma cells, an involved free light chain ratio over 100, or more than one focal lesion on an MRI, we don't wait around for their bones to break or their kidneys to fail. These markers allow us to diagnose and treat active myeloma based on biological inevitability, well before classical organ damage ever occurs.
Section 5, divergent pathways and emergencies.
Not all clones play by the same rules. For example, finding an IgM protein? That's a totally different ballgame. You have to carefully differentiate a rare IgM plasma cell myeloma from Waldenstrom's macroglobulinemia. We do this by relying on specific flow cytometry, looking for CD20 positivity in Waldenstrom's, and molecular markers like the MYD88 L265P mutation, since their treatments are completely distinct.
We also have to hunt for the dangerous small clones. It's a really surprising fact of hematology that a nearly undetectable protein burden can cause catastrophic damage. This can happen through amyloid deposition requiring a Congo red stain, the severe cytokine storms of Pulm syndrome causing demyelinating neuropathy, or MGRS, where a tiny clone aggressively targets and destroys the kidney.
Now, in the acute setting, you've got to instantly recognize plasma cell emergencies. Whether it's the acute kidney injury of cast nephropathy, cord compression requiring urgent surgical assessment, or the newly updated 5% circulating threshold for primary plasma cell leukemia, seeing any of these signs triggers immediate, aggressive clone control.
Finally, Section 6, Treatment Algorithms in MRD.
For fit, transplant-eligible patients, the standard algorithmic sequence is a multi-step powerhouse. We utilize a deep anti-CD38-based induction therapy, carefully collect those stem cells, deliver high-dose malphilant conditioning, proceed to an autologous transplant, and then lock in that response with continuous, risk-adapted maintenance.
But unfortunately, relapse can happen. When it does, we've got to sharply distinguish what kind of relapse we're looking at. A slow biochemical progression, where just the protein numbers are creeping up, might just need close monitoring. But a clinical relapse, signaled by new lytic lesions or renal deterioration, requires rapid, aggressive intervention. That's where we often turn to novel agents like CAR T cells or bispecific antibodies.
To truly measure treatment success today, our ultimate goal is minimal residual disease, or MRD negativity. Using incredibly sensitive next-generation flow or sequencing, we are literally looking for just one cancer cell in a million. Achieving sustained MRD negativity indicates durable, deep clonal control well beyond what a standard complete response could ever tell us.
As we've seen throughout this explainer, modern hematology requires seamlessly integrating pathology, radiology, and clinical presentation. It's all about the biological effect, not just the clone size. So the next time you see a monoclonal protein on a lab report, are you going to be the detective who tracks down its true biological effect?